multimodality management of cases with voting, and we will use our hands instead of the voting pads. Professor Clough and Professor Spillman and Professor Bindorka will moderate this session about the multidisciplinary management. It's a very important session, and we will start the clinical case now by the presence of high-caliber panelists, Professor Sharif Naguib, Professor Nadia Mukhtar, Professor Moiz Namer, Professor Ala Andil, Professor Mati Abro, Professor Elia Anis, Professor Nagla Abduraze, Professor Pascal Poujoul, Professor Frédéric Ben Lorca, and me, Shamil Ghazali. Thank you very much.
Good evening, everybody. The first case will be presented by Krishna Clough. It is a case of BRCA2 breast cancer, and if you agree, it's possible to start now. You have the... yes.
So this is a real story to tell you how simple things can get complicated in our business. This real patient comes to us. She's 40 years old. She's a journalist. And you have to remember until the end of the case that she's a very well-informed European journalist on the internet all the time. She has 2 children. Her mother had breast cancer. Her aunt, mother's side, her great-aunt, mother's side, had breast cancer. And the patient was diagnosed, Mrs. S.G., with a BRCA2 mutation. So she comes for her first consultation and she seeks advice. Of course, she's read everything on the internet, but she wants advice. When you examine her, she's thin, 60 kilos, small-breasted woman. We always put the volume of the breast in our files because for surgical indications, it's an important matter. She's a smoker. She smokes 10 cigarettes a day. She has no palpable tumor, no nodes. Her mammo, her ultrasound are normal. She's perfectly fit, no abnormality, and she wants your advice as a breast specialist as she's carrying a mutation. Here are the propositions. What would you recommend? Would you recommend a prophylactic mastectomy? Would you recommend hormone therapy? Would you recommend any other?
Okay, if you agree now, we have to vote. All the medical doctors in the room, okay? For the first proposition, first option, could you raise your hand? Prophylactic mastectomy. Okay. Second one, tamoxifen. Okay. And other option. Okay. In the panel, we have other option. Mrs. Nagla, could you explain your position?
She's young and have BRCA positive gene. She didn't do MRI yet, so I recommend the MRI for her.
And you? What do you propose, Mr. Pascal Pujol?
I fully agree because sensitivity of MRI have been shown to be very superior to the sensitivity of mammogram for at least 3 reasons. The density of this young woman, the sensibility, and also because in some of BRCA1, especially BRCA1, there is some basal-like lesions that could be hard to detect by mammogram. But this is 2 different options, and I think the first could be discussed with the woman. It could be his choice, like Angelina's case. It's a personal choice driven by perception of the risk, family story. And so this could not be avoided from the discussion. But I agree that MRI will be the option for screening.
Okay, let's go.
Frédéric.
No, Mrs.
She has already breast cancer, so...
Non.
No, not already? Okay.
Non. Ok.
Bah, tu les as fait avec nous quand même. Enfin, c'est quoi, Fred? Qu'est-ce que tu as donné? So the message here is, before proposing a prophylactic intervention, should it be surgery or tamoxifen, just complete the workup, the pre-decision workup. And she did not have a full pre-decision workup, as she did not have MRI. So you cannot propose a mastectomy or tamoxifen just because she has a mutation if you're not sure she's not a cancer carrier. So what we did is we did an MRI. And the MRI showed on the left breast a nodular image on the lower pole, which was seen by a very expert radiologist, very round, non-suspicious. ACR3 was the conclusion of the radiologist. So what are your suggestions? Would you recommend MRI-guided biopsy? Don't forget that lump is not palpable, it's not seen on the mammogram, and it was not seen on the screening ultrasound. Would you propose a new MRI in 4 or 6 months? Would you propose a wide local excision? Or do you have any other suggestion?
Okay. Alors for the panelists,
Nagla.
what? Just one moment. We have to vote. Okay. The first option is MRI guide biopsy. In the room, what do you prefer to? Okay. In the panelist, medical doctor, Mr. Mattia Pro.
I recommend the second look ultrasound. We have to go for to look for the nodular density, the nodular lesions that was found in the MRI first before starting to do MRI guided biopsy, which is not available everywhere and it's difficult. We can find the lesion by ultrasound. So we have to check for the lesion in ultrasound first.
Okay. Mr. Nehmer, what is your choice? No? Okay. Mr. Apro?
I want to go where the gold is, so I would like to do a biopsy.
Okay, so this is what we did. The first ultrasound was a screening ultrasound. And now you have an image on the MRI, and you have to know that the number of patients who have an image on the MRI that go back for a second ultrasound and look at the radiologist are found with a lesion that was not found at the first ultrasound, because now the radiologist has a better target because he or she has the MRI. So we did a second look ultrasound, and this clinical case is also for you to improve your French. So she had a microbiopsie d'un nodule situé. Okay, I'll say it in English. So 8 millimeter lower pole, still considered to be looking like a benign lesion. However, this patient has a mutation, she has an image on MRI, she has an image on the ultrasound. Even though it looks benign, she's an indication for ultrasound-guided biopsy, which is what we performed. And the answer is she has lobular neoplasia, if you want to read it in French or in English, such as this lesion, grade 2 with grade 3 errors. What do you suggest now? She has a mutation. She has a biopsy that shows lobular neoplasia. Would you suggest tamoxifen, surgery with frozen section, or go immediately for a mastectomy?
Alors, for the first option A, we raise our hand. Okay. Option 2, what local excision? Okay. Third one, what local excision plus frozen section and sentinel lymph nodes? Okay. And the fourth one is mastectomy, uni or bilateral. Okay.
Okay.
I would
So-
like to know, Mr. Sheriff Naguib, your advice.
I would go for a wide local excision with frozen section, definitely, because she has an important family history, and she has a gene mutation, and lots of times lobular carcinoma radiologically doesn't really look suspicious. So I would go for wide local excision and frozen section, definitely.
Your option, Krishna?
Okay, something is wrong in this global picture. You have a discordance between radiology and histology. If you have a nodular image which looks round, there is no reason to have lobular carcinoma in situ. So that discordance between radiology and histology triggered us, and we thought that she might have more than lobular carcinoma in situ. We could have gone for mastectomy if it was the patient's choice, but you're not going to do the same mastectomy if he's carrying a cancer or if it's just prophylactic. So just as you suggested, we went for wide local excision, frozen section, and frozen section demonstrated that it was an infiltrating ductal carcinoma, 10 millimeter, with some areas of lobular in situ, peripheral, which are the areas that were biopsied. This invasive ductal was not biopsied. However, here are the prognostic features. 10 millimeter, grade 1, low mitotic index, estrogen receptor, progesterone receptor 100%, HER2 1, Ki67 15%, free margins thanks to frozen section, who allow us on the lumpectomy specimen to re-excise if necessary. 3 sentinel nodes were negative. So we start with lobular neoplasia, and now this patient, 40 years old, is carrying a mutation, plus she has an invasive carcinoma that you might discuss about the prognostic.
And Mrs. Mokhtar, what do you think about this patient?
Would like, well, you have to do the molecular markers, of course, the hormone and the HER2 and the Ki67 on the biopsy as well as on the excision specimen, just to make sure that we're getting the whole picture.
Mr. Elia, what do you think about the prognosis of this patient?
Actually, it looks nice. Low ER and PR positive, and a low grade. Unfortunately, the gene mutations. So we're still on the verge of a strict follow-up.
Okay, so now we turn over to the medical oncologist and we say, what is the systemic treatment? Mark, dear colleagues?
Yes.
Okay.
Probably this patient has a very good prognosis, and the treatment
Luminal A.
will be a sample treatment.
Straightforward luminal A disease. I'm Hisham.
Okay.
Yes, there are straightforward luminal A, very good prognosis, very low proliferation index, strongly positive ER and PR. So the hormonal treatment will be fantastic with her, and the best for her is tamoxifen.
Okay, we have 3 options. First one, tamoxifen alone. Second one, LH-RH analog plus tamoxifen. She's premenopausal. Third one, LH-RH analog and aromatase inhibitor. What is your choice? For the first one, for tamoxifen alone, could you raise your hand with me? Okay, now, for both, tamoxifen and LH-RH analog. Okay. And the third one, LH-RH plus aromatase inhibitor. Okay. In the panel, Mr.
Chemo? Chemo? Nobody votes for chemo?
For chemo, we have possibility to do chemo for this patient?
Problem is Professor Al-Ghazali said no, so everybody would say no, huh?
It's difficult.
It's his meeting, right?
And what is your choice, Professor Nehmer? In hormonotherapy in this case?
She needs, the most important is tamoxifen and radiotherapy. And she is really borderline for adjuvant treatment. She's a very low risk patient, so at maximum tamoxifen for me.
Okay.
Professor Kandil?
Well, I would also repeat the same. Actually, she's the low-risk patient, very strong ER, PR, negative HER2, low Ki-67, negative lymph nodes. So she's a candidate for adjuvant hormonal therapy, which is, in my preference, is tamoxifen, and I would put LHRH analog in addition to that. Yeah, there's no consensus to this point, but I would prefer, in her case scenario, to add that to tamoxifen.
Okay. Mrs. Penolaka.
I just want to remind you that she's mutated. Does it change anything in your practice for that? She's at risk of recurrence of breast cancer, but it's a small tumor, it's a TAB, and it's a grade 1 low proliferative luminal A tumor. So can we go further trying to characterize better this tumor? Couldn't she a candidate for a molecular signature, for instance?
Elle est futée, hein? Elle est futée. So this is what happened in real life. Our recommendation was tamoxifen, no discussion for chemo, no discussion for analogs, because no demonstration. But if you're in Paris and if you're a journalist and you have a breast cancer, you're going to three or four medical oncologists. By the way, you might see 3 or 4 or 5 surgeons. So out of the 3 or 4 medical oncologists, one suggested that chemotherapy might be a solution. So now our journalist is terrified. So she goes online and she sees that she can get Oncotype DX, which in France is not refunded by Social Security. So she comes back to us and she says, you advocated tamoxifen, I would like an Oncotype DX. So Oncotype DX was performed at her demand. We did not recommend Oncotype DX. So her score, her recurrence score was 18, which puts her in the higher first third, between first third and second third. So no benefit for chemo. So here is our journalist perfectly convinced that she is treated according to the best international standards. So far, for medical adjuvant treatment, but she has a small infiltrating breast cancer, free margins, very good prognosis, 40 years old, and she has a mutation. What is the local treatment? Would you recommend, or maybe at this stage, we can't recommend anything. Would you say that she can have radiotherapy, she can have mastectomy with immediate reconstruction, total mastectomy? Is she a candidate for nipple-sparing mastectomy, or is she a candidate for nipple-sparing mastectomy with partial breast irradiation on the areola? And all these options were discussed with that singular patient.
Okay, we have to vote for the option A, 1. In the panel? No, now for radiotherapy alone. Second one is mastectomy plus what? Immediately reconstruction. Okay.
Total mastectomy with immediate reconstruction.
Okay.
Total mastectomy is number 2.
And number 2? Number 3 is nipple sparing mastectomy and reconstruction. Okay, immediate reconstruction. Number 3. And number 4, a nipple sparing mastectomy, immediate reconstruction, and PB irradiation.
Partial breast irradiation.
Like in Milan.
Okay.
Alors,
would anybody on the panel comment all this, or anybody in the room?
For the first option, we have no vote. In the panel, for the first option,
I feel that it is.
I think, her situation is quite clear. In this case scenario, radiotherapy wouldn't be an option for her. She had a conservative treatment. She's a candidate for radiotherapy. Why complicate things with the other three options? I really don't find that. So radiotherapy is a good option for this patient.
Okay.
what is your option, Krishna?
Well, I think all options are.
Yes.
You can discuss them. She's a candidate for radiotherapy. We'll see why. She can also ask for a mastectomy to reduce her risk of second cancer. But having a nipple-sparing mastectomy with an invasive carcinoma is still a question to be debated. Why can she have breast conservation? And I was surprised to see that we didn't have more demands for mastectomy, because up to date there is no evidence that a patient who has a mutation and a small invasive breast cancer with complete excision-free margins has a higher risk of recurrence than a patient who does not have a mutation. And this is a very important point, because in some groups, this patient would be proposed for the mastectomy because she would be told that her risk of recurrence is very high on the ipsilateral breast, on the breast that carries the cancer. The analysis of the literature is still blurry, and we don't have a straightforward image on that, but she's definitely a candidate. One of the options could be breast conservation. Anybody wants to comment that on the panel?
Sharif, what is your option in this case?
Actually, Krishna has been terrorizing us with her being a journalist. So I'm terrorized. I will probably close my clinic and go for holiday, and I will not see the patient. But anyway, I think radiotherapy is just enough. I don't think she needs any further surgical intervention.
And I didn't tell you her husband is a lawyer.
Now I'll go for a very long holiday.
And her baby girl is a judge.
That's
okay.
Just a small comment. It's not the recurrence, actually, it's a multicentricity problem because of her lobular element. So radiotherapy would be so beneficial in that occasion. Yes, I agree.
I think this is a very, very difficult question for this reason. What is questioning both the patient and the doctor is that we are just mixing two different medical questions. The first one is about treatment of a breast cancer, and the second is a preventive question. And that is very difficult to deal with. I mean, when you are dealing with one question like breast cancer, it's already a big deal, right? So now you are coming with two questions, mixing actually. So I think there is no particular option to be put really on the advice. We can recommend this woman option A, B, C, and D. We can help her to make the right choice depending on her demand, but also by sometimes relativizing what you say, that there is no increase in local recurrence if we opt for conservative surgery. So this is a very complicated question. There is no solution. The solution is just to discuss with this woman.
So we did. And as we did discuss more and more, she said, okay, I want a mastectomy because I understood, Dr. Clough, you're telling me that my risk of recurrence is no bigger than a patient who doesn't have a mutation, but I am 40 years old, so I don't want the second cancer. So I said, fine. So in that case, I'll do a mastectomy and immediate reconstruction, bilateral, if you want a risk-reducing operation. But she says, no, I want a nipple-sparing mastectomy on the left side. And I say, no, you won't have a nipple-sparing mastectomy because you have invasive cancer, which is not far away from the nipple, and it's contraindicated. And then she says, I was on the internet, and I saw that we can have partial breast irradiation. So I said, yes, but not in France, because it's not standard. So there are teams in Europe who are perfect specialists for that indication. So she took a plane and she went to see one of the best teams for partial breast irradiation in Europe. And as she required, she had a mastectomy, bilateral, nipple sparing, intra-op radiotherapy, left areola, no residual disease, and she was happy. Post-op was uneventful. She left that hospital day 3. Drains were removed in Paris, day 10 and day 4. She traveled back. Day 30, all was okay. I kept calling her to get news because she's a very nice person. And she said, okay, Dr. Clough, it's very nice, but I have a little discharge on both breasts, and my skin is very thin, and it's bluish. I said, bluish? Go back, take that plane. And she said, no. It's very bluish. So I say, come over. And this is the real story of that patient. She had a perfect immediate result, absolutely perfect. And 1 month after surgery, don't forget she's a smoker, she has high risk factor, thin skin, and the implant started extruding. So now you have bilateral implant exposure. And for the surgeons in the room, what would you recommend? Lavage, drainage, put back an implant? Let's make it quick. Anybody wants to put back an implant here? No. Expanders? No. A cellular dermal matrix? Anybody is ready to go back? A cellular dermal matrix and implant? Bilateral latissimus dorsi? Other. Mark will go quickly for the sake of time. So this is what we had to do. We removed bilateral implants, and as she is 8 months later, she was radiated on that side only, not on this one, but you can see that the skin is very thin, attached to the ribs, and she demands reconstruction. What are the options? Just for the surgeon. Anybody wants to put an implant? No? Anybody wants to expand that thin skin? No. Anybody wants to send her in another country? Yes.
Or the flap?
Anybody wants to do bilateral latissimus dorsi, which could be an option. And my suggestion 10 years ago would have been bilateral latissimus dorsi. She has no abdomen, she has no butt, so it's just skin and muscle in the back. But now we have another option, and the other option, we'll discuss about that, and Jean-Yves talked about that, is lipofilling. We harvested fat in 3 sessions in 3 sessions under general anesthesia, outpatient, to help elevate that skin from the rib, and we finally could put implants. That patient was operated 6 times. She went 6 times to surgery. Her option was to have a risk-reducing mastectomy, but I think it's a good thing that all of us here agree that the other option would have been conservative treatment, and we don't have the answer. You want to talk about the last question?
No.
Now?
Do you have the last question on this case? No?
Les ovaires? Tu veux parler des ovaires ou?
We have now the problem. Yes.
So, last question is, she is still a journalist. And she still has questions.
Yes.
And she says, Dr. Clough, okay, for the breast, I was operated 6 or 7 times. Now I'm happy with the results. But what would you recommend